can I just invite Tony, if you want to come up, because we can move into the panel. I've got a couple of other questions. The rat accuracy, and Daryl's going to online, I think, so that we can ask those questions, and we've got some. We've got a question down the back there. Yeah.
Thanks, Paul, for a great talk. Just wondering about counselling for adverse events, particularly rare adverse events like Guillain-Barré syndrome. Any thoughts on that?
Yeah, look, obviously these conversations are getting increasingly challenging, and I think the main thing is just to be informed with as much information as we can be and have an open and honest discussion with people. I mean, you know, there's so much misinformation out there that, you know, we don't necessarily talk about these things, but, you know, we know there are adverse events with every medical intervention that includes vaccines, and as I say, I think just highlighting those, but obviously putting them in the right context, that the burden of the disease is very, very significant. The risk of adverse events, particularly significant ones, is extremely rare. And if that wasn't the case, we simply wouldn't be, you know, using these vaccines in our country.
I've got a question. A question online again was, you said rats are being done, rapid antigen tests are being done, and so the actual incidence of disease is a bit of a question. How reliable is it if someone presents to you and says, oh, my rat's negative? Do you take that for granted, or are you still recommending?
Yeah, look, the rapid antigen tests have a role without question. They're a really good, easy screen. You can get them from the local pharmacy, but there are a lot of limitations. Obviously, it's very technique dependent. We've seen a lot of people store them since the height of COVID and pull out these expired rats 3 years down the track and get a negative and think that's fantastic. So they do have a relatively high false negative rate. I think flu B is the highest, but certainly you know, you can have one of these viruses do a rat and get a negative, and what we don't want people to do is say, that's great, I'm negative, I'm going to go and visit nursing home or the neonatal ICU and all those sort of things. So my advice would be they're a great screen, believe the positives. If you're very symptomatic and negative, still assume you're positive and consider getting a PCR-based test.
I've got a question. Thank you for Daryl for coming back online. Hang on, I've lost the question. Sorry, have we got anyone? Okay, one from the audience while we're waiting, sorry.
Thanks. Hi, Paul and Tony. Jamie Trickus from the University of Sydney. I think this intersects between both of your presentations. Paul, you mentioned there was a question about the longevity of the response. And I guess one of the issues during COVID with the different platforms was this, eventually it's perception, there was a thought that the protein vaccines, for example, would be more longer lasting than the mRNA. I think Tony will say no, but is there any data, and one of the good things I guess about RSV is we have these different platforms that have gone out for many years, although noting that I don't think the Moderna vaccine is approved in anywhere or many places, the RNA vaccine. So is there anything that looks at longevity over a couple of years between these different platforms with RSV?
So is that Tony or?
Well, we can both reply.
Yeah, start Tony and then I'll get down.
Well, Arexvy is 3 years up till now, Brisvo is 2. And you may know about the RNA vaccines, but the one thing I just wanted to point out is that the AS01 dose in Arexvy is half that of Shingrix. And as we discuss, AS01 has never really been optimised in terms of dosage. So the advantage, of course, is you reduce the number of severe adverse events with Arexvy to under 50% of that Shingrix. So it's about 4% as opposed to 11%. But the interesting question is, how do you balance side effects and longevity? We know Shingrix will go for more than 11 years, probably 20. The issue with Arexvy is you're looking at respiratory infections rather than systemic reactivation infections. So I think a lot to learn, and I think it's very clear RNA vaccines do not have the longevity of some of the best adjuvanted protein vaccines, which is a challenge. One of the things we're working on is to look at how you might incorporate adjuvants into RNA vaccines in the future, which I know you're working on.
So do you want to add to that? No?
No, I think I absolutely agree, and it's probably just a bit early to really compare them too much. I think there'll be more information coming in the next few years.
And Daryl, did you want to comment on that, or did you hear that question enough to answer?
Yeah, look, I think it's probably related more to the adult population than it is to the maternal population and infant population. So suffice to say that I think Paul's right. We need more data, and it's got to become clearer. For us, we have the obvious balance between the two. We know that the mRNA vaccine at the moment for RSV is not being approved for children, and there are some concerns around that and has been discontinued from some ongoing trials. So that remains a watch and see space as well for us in the infant population.
So there was a question about longevity in pregnancy. How many pregnancies does one RSV vaccine do?
Yeah, so that's the million-dollar question at the moment. The current recommendation in Australia is not to have a repeat immunisation for a second pregnancy. I just note, again, I'm just observing around the world, there are different recommendations. I know some countries are recommending for a second pregnancy, you get a repeat. I think that data will become clearer as we have more evidence throughout. There is also some discussion around the impact and the timing of that. As you're aware, it's not a set timing for a maternal vaccination to be administered at a particular time. There's a range window between 28 and 36 weeks. And so that in itself has some discussions. There's some studies coming up in North America in terms of the more timing in maternal. So there are a few moving parts to that. We don't have a clear answer at this point, but the recommendation at the moment is just a single dose for now and no repeats in future pregnancies, although that may change depending on the data that we start to see across multiple seasons and also some of the longer term impacts. I think for infants and children, one of the questions that has often been asked is what is the impact of this in terms of longer term prevention of sequelae of RSV? We know that RSV infected infants then are more likely to develop preschool wheezing and asthma down the track, 2 years old, 3 years old, and so on and so forth. One of the clear questions is which of, does repeated doses help to reduce the long-term impacts, which has a significant impact on the economy and society and the healthcare system as well. So those are questions that I think are still yet to be answered by, we just don't have the data available yet here in Australia, but also overseas.
David Muscatello from the University of New South Wales. This might be a naive question, but are we, with RSV vaccines, are we likely to need to have to update the antigens annually like we do for COVID or influenza vaccines?
The thought is no, I think at this stage is probably where the thinking is at the moment. So I don't think there's any indication there's going to be a need for updates, fortunately. But, obviously it'll be something that'll be watched very closely with now the advent of all of these interventions.
Sort of covers subtype A and B, which indicates, there's quite a good degree of breadth with both vaccines.
Thank you.
And while the microphone's getting to John, we had a question just to clarify the residential aged care homes and the Victorian funded program. I think it was for Indigenous, wasn't it?
Yeah, so my understanding, there's probably people in the room with far more experience than I with this, but yeah, people over 60 in Aboriginal controlled community care centres and certain residential aged care facilities, I think, or words to that effect. So yeah, it's still a fairly limited group that are eligible, but it's a step in the right direction.
John?
Great talk, Paul. Co-administration. There's some data presented to ACIP a couple of years ago with the adjuvanted vaccine that the H3 titer was actually going to be slightly lower, but it was not seen with the high-dose one. TGA and ATAGI have largely said you don't have to worry about it, but we know that H3 is problematic. We don't get good sort of growth in non-egg cell culture things there, and it causes more morbidity. So I would personally say separate them, but ATAGI's not saying that. But if you want to get a maximum bang, is there any more data on that in terms of any alteration of the immunogenicity when you're giving two vaccines together?
Yeah, look, it's a great question. I'm not aware of great data that confirms that either way. I think it's a bit of a balance between the benefit of co-administering, and it's going to come down a little bit to if you've got a patient who's very reliable, you see often, and you can reliably get them back in a couple of weeks, there might be a subtle benefit in spacing them out, and some of the evidence suggests maybe give the RSV first and then give the others on the second visit. But I think, on balance, even with some questions around a modest reduction in immunogenicity, if you've got a patient who you're not sure you're going to get back, the benefit of just getting those vaccines in probably outweighs any potential slight reduction in immunogenicity. So again, it's one of those things, watch this space, but I certainly think if people have an opportunity, you can co-administer all three.
Can I just comment on that? I mean, mechanistically, if you immunise at the same time, you immunise in opposite shoulders because the lymph nodes are separated from each other. So if you're going to put RNA vaccines together, it's incumbent on looking at the immunogenicity, and in some cases you've needed to increase the dose.
Daryl, is there probably scenarios you might be a flu vaccine a certain type of year or a whooping cough vaccine that you might need to co-administer? Any questions, comments?
Yeah, so the co-administration is mainly for the maternal, obviously pertussis, flu and RSV at the same time. The window allows for that opportunity, and I think one of the benefits of maternal care, at least here in Australia, is that there are regular scheduled antenatal visits already, which helps to either spread that out or have them all together coincidentally if the woman does decide to do that. I think that for the infant, generally speaking, we do have nirsevimab available across a whole range of settings now, and often in that age group, it's more about convenience rather than the concern around the co-administration, understanding that many infants get a number of immunizations at the one time. At the 2-month mark at birth, they get vitamin K and hepatitis B, obviously together, and so that is probably less of an issue for the infants, and the convenience of having nirsevimab available, if that's the product that's needed, in the hospital, on the maternity birth suite ward, as well as at GP practices and other facilities, also means that the parents have choice in terms of where they can get that opportunistically, depending on where they're visiting for care for their infant.
2 legs, 2 arms, lots of sites for vaccines. We've got a couple of questions there.
Hi, hello, my name is Barsha and I'm from Northern Health. My question is, what adverse events are associated with receiving the, mistakenly receiving the double dose of RSV vaccination, particularly during pregnancy? We are trying to do opportunistic vaccinations, but, often it's difficult with the diverse communities with the access to AIR and IHI, where there has been reported adverse event related to double dosing, but we don't really know what's the adverse event associated with that, or is there any doubt out there?
So is that Daryl's?
Yeah, I can try and answer that. Look, we haven't yet seen any significant impacts around that. So there is a number of potential possibilities. We've most commonly seen the maternal vaccine given to the child by accident instead of the monoclonal antibody. We've rarely seen the monoclonal antibody being given to the adult just because of the dosing, and usually it's about where these products are kept and the confusion between the two, either at primary care level or in the hospital setting. There's no at this point in time, there's no indication to that question if a mother unfortunately receives a double dose of immunisation that there have been any significant impacts. Obviously, the protection is for the child in terms of protecting its RSVs from maternal antibody transfer anyway. So the stimulation of that is a secondary impact, or is the impact of the vaccine. So we haven't yet seen that, although any significant adverse events of concern from what we've observed from those, although we'll continue to keep an eye out that from a safety surveillance point of view.
Thank you. Ian?
Yeah, Ian Barr, Doherty Centre. Daryl, you mentioned very briefly the issue with the Moderna pre-F fusion vaccine in children. Do you think that's going to stall the program? We thought we had all the answers with putting a pre-F in instead of the post-fusion. Where are we now? Are we stomped again?
Yeah, that's a good question. I think it's interesting, Ian, because I think there's a component of it which it's a double-edged sword. More options is often more in this day and age, particularly around, when I mentioned vaccine hesitancy and misinformation, more options may be sometimes better in terms of helping our families, infants, parents, etc., choose one of the three, even though we have specific recommendations. I think from a scientific perspective, it throws a spanner in the works and makes it challenging for us to be able to do that. Given the history, I think if the history wasn't there, it may be a different story. I think for reference, some of the history from the 1950s in terms of the significant impacts and the adverse events and of early vaccination. So I think from a scientific perspective, I think that there are some significant challenges there. But ultimately, it also will then come down to the other edge of the sword is that more options is good, but then which option is going to provide optimum protection against all those questions which people are asking now, right? So if an mRNA vaccination eventually can conquer that hurdle that we've seen to face for the last 70 years, what benefit is it going to provide from a longer term perspective? And some of the longer term sequelae perspective, I think, is of interest to people, and that may swing people one way or the other in terms of having that availability. So I wouldn't say it's a death knell or curtains definitely for that, but there are significant challenges there still to overcome.
I've got a question online. Do we have to call the monoclonal antibody an immunisation or a vaccine so it can be included in the national immunisation program? And while it sounds like a slightly obscure comment, I think it makes some legislative changes because they're treated differently and funded differently and brought into Australia. So would you have any comments? Can you call it an immunisation or a vaccination? Tony?
It's immunotherapy.
So maybe we should call all vaccines immunotherapy? So, sorry, did you?
Well, we've got, we have vaccines which not only operate prophylactically, but therapeutically. You can even say Shingrix is a therapeutic vaccine. You could say the same with RSV. Yeah.
So it may make a difference in the future if they're classified because they're looked at as a drug or if they're looked at as a vaccine, and the implications. While it sounds a very sort of superficial and perhaps obscure question, it actually...
I think the scientific overlap, it's how the regulators see things.
Well, that's what I'm putting to you.
And I think we just need to have a system that's a bit more agile. These things, we're getting so many advances. We've got vaccines for cancer, for example. I just hope the semantics of the definitions don't hold up how we utilise these products. So hopefully the system can sort of catch up with where we're up to and that there's no hold-ups there.
So Daryl, you're going to classify it as you're vaccinating your children?
Yeah, it's a really good question. For us in the infant space, I think, as I mentioned before, 100% agree with Paul and Tony that looking at this from a semantic legislation, air records, transferability of data, it's vital that we try and push to ensure that there's an encapsulation of this. RSV is the first example, but there's going to be more coming along the line, that we need that access to be able to effectively prevent, protect, and not run into issues with duplication and safety events. That distinction, though, is actually sometimes useful. Again, I hark back to that whole conversation around vaccine hesitancy and misinformation. I've had many families who have had conversations with, but when they understand the nature and the construct of some of the difference between the maternal vaccine and the monoclonal antibody, they've made a conscious choice that they said, okay, I'm not going to get one, I'm going to get the other because of understanding that it's a slightly different angle. So there is some benefit into distinguishing those two things, but from a practical legislative record, health record point of view, health data perspective, it makes no sense to separate them out arbitrarily based on the mechanism of action. Realistically speaking, if you look at it, we've called the entirety of this exercise, at least in the infant population, a preventative program. And the program is because we have different options in the program to prevent. So we see it from a scientific perspective as a holistic approach rather than separating two out just by a mechanism of action.
Yeah, so I know when we introduced the HPV vaccine, it was a cancer vaccine, not a promiscuity vaccine. Yeah, so David, did you want to comment? Yeah.
I just wanted to say that one of the reasons why we have the two different programs, the maternal and then for the Nisivimab, was because Nisivimab didn't meet the definition of a vaccine in the legislation. The Parliament has actually just updated that legislation that paves the way for some of the other MABs to be on the National Immunisation Program in future.
That's why the Commonwealth, it's good to have you here to know that, so thank you. Any final comments, and then we'll finish this session. Tony, any final comments?
No, I just think, again, to clarify what I just said, is in my field of herpes virus vaccines, we're seeing prophylactic and therapeutic. And so there's this scientific overlap of how you use vaccines and immunotherapy. And I think it's really important we don't get hung up on
so
on
that's
the
good to hear
differences.
this. Yeah, and final comments. And Daryl, any final comments? And thank you again.
No worries. Thanks for the opportunity to present. No final comments. I think it's very exciting what we've seen so far in terms of real world, and it's very exciting to see that impact even in the first partway through the second real season, and we look forward to seeing that longer term data come out and also hopefully rub off on what has been a very successful infant program to then benefit our elderly population as well and other high-risk populations, as Paul has referenced, because overall we see this as something really important.
So thank you very much for a very interesting and energising first session of the morning. Thank you very much. Thank you for our speakers. Thank you.